Hello, this video is going to be about the background and neurobiology of premenstrual dysphoric disorder. So what exactly is premenstrual dysphoric disorder? PMDD is considered a severe mood disorder characterized by cognitive affective symptoms as well as behavioral and physical symptoms that are apparent during the week before menses. PMDD is defined as a depressive disorder in DSM-5 and affects millions of women worldwide. Let's have a quick recap of the menstrual cycle in order to understand a few terms that will be seen throughout this video. So the menstrual cycle consists of 4 phases. The first phase is the menstrual phase, which starts on the first day of a woman's period. The follicular phase follows, which is the preparation for ovulation. FSH, follicle stimulating hormone, stimulates ovaries to produce a mature egg, which produces estrogen. Because of the increase in estrogen, women might experience having increased energy during this phase. The ovulation phase is when the matured egg is released, as well as high levels of estrogen. Boosts in energy and inspiration, as well as increase in sex drive, are seen during this phase. The luteal phase is the end of the menstrual cycle. During this phase, progesterone is released in order to make sure that the uterus continues to build up its lining in case an egg is fertilized. The increase in progesterone will cause stress levels to increase. Women might feel moodier, irritated, or sad during this phase. If the egg is not fertilized, levels of estrogen and progesterone drop, and the lining of the uterus breaks down and the menstrual phase starts up again. Okay, so according to the DSM-5 criteria, in order to be diagnosed with PMDD, women must have at least 5 of the affective or behavioral cognitive symptoms, which we will discuss after this slide. And at least one of the 5 symptoms has to be an affective symptom. These symptoms must be present for most of the time during the last week of the luteal phase and go away within few days of the onset of the menstrual phase. Symptoms must be severe enough to interfere significantly with functioning in the patient's social, occupational, sexual, and/or scholastic life. Symptoms must be relevant to the menstrual cycle and not be the worsening of the symptoms of another disorder, such as major depressive disorder or panic disorder. The criteria mentioned has to be confirmed by a diary or some sort of prospective daily rating during at least 2 consecutive symptomatic menstrual cycles. Some affective symptoms are lability of affect, irritability or anger, which are characterized by the increase of interpersonal conflicts, marked depressed mood, hopelessness or anxiety, tension, or feeling on edge. As mentioned before, in order to be diagnosed with PMDD, women must have at least one of these symptoms. The rest can be behavioral cognitive symptoms, such as loss of interest in usual activities, difficulty concentrating, lack of energy, changes in appetite or food cravings, changes in sleep. This can be hypersomnia or insomnia, feeling overwhelmed or out of control, along with physical symptoms such as breast tenderness or swelling, headache, joint or muscle pain. So, let's talk about the etiology of PMDD. The first is genetic susceptibility. There have been studies that have shown that there is about a 30 to 80% heritability range demonstrated and supported by different family and twin studies. Another piece of evidence that PMDD has to do with genetics is the ESR1 gene, which stands for estrogen receptor alpha gene. ESR1 is important for arousal. If dysfunctional, this gene could be implicated in the somatic as well as the affective and cognitive deficits in PMDD patients. Lastly, there have been studies that have tried to find a connection between serotonin gene polymorphism and PMDD, but research has yet been able to find a connection. Although these studies couldn't find the connection between the two, they have found that the presence of at least one cytosine allele was associated with 2.5 more times of an increased risk of developing PMDD. Progesterone and allopregnanolone. Progesterone, as mentioned in the review of the menstrual cycle, is released to help regulate the lining of the uterus. Allopregnanolone, also known as allo, is the main metabolite for progesterone. Both progesterone and allo are thought to play a role in the etiology of PMDD. In both women who have PMDD and those without, experience low levels of progesterone during the follicular phase and high levels during the luteal phase of the menstrual cycle. Those with PMDD have been reported to have decreased levels of allopregnanolone in the luteal phase when compared to healthy controls. As seen in the graph to the right, those with PMDD in red have lower levels of progesterone in the follicular phase and luteal phase when compared to the healthy controls, which are in blue. Allo is a potent allosteric modulator of GABA-A receptors and has sedative, anesthetic, and anxiolytic properties, which are also seen with alcohol and benzodiazepines. In times of acute stress, increased allo is known to provide relief. But women with PMDD, this typical allo increase during acute stress does not occur. There are animal models which portray the importance of progesterone and allopregnanolone in PMDD. A study done on rats and the withdrawal from physiological doses of progesterone exhibits social withdrawal and lack of pleasure from activities usually found enjoyable, which are symptoms characteristic of PMDD. Another study showed that chronic exposure to progesterone, followed by withdrawal of progesterone, portrayed increased anxiety behavior as well as alterations in the GABA-A receptor function in rats. The alterations in GABA-A function may not be due to progesterone itself, but allo, as blocking progesterone conversion to allo blocks the previously mentioned effects of progesterone. In the last study I found, manipulations that produced depressive and anxiety-like symptoms in mice were associated with reduced allo levels in the amygdala, hippocampus, and the medial prefrontal cortex in these mice, making the connection that allo directly affects PMDD. Estrogen, serotonin, and BDNF. So the relationship between estrogen and serotonin aren't fully understood yet, but we do know that they both play a role in PMDD. Estrogen affects multiple neurotransmitter systems that regulate mood, cognition, sleep, and eating behavior. PMDD symptoms align with low estrogen side effects. PET studies done in humans have found increased cortical serotonin binding modulated by levels of estrogen. Another study also showed that there was an increased binding potential of serotonin in the cerebral cortex with estrogen treatment, and an even greater binding potential of serotonin with a treatment combination of estrogen and progesterone. Another study showed that low levels of estrogen were associated with decreased serotonin transporter gene expression. As estrogen decreases, levels of monoamine oxidase decreased, which is responsible for breaking down monoamines like serotonin. We know serotonin plays a role in PMDD because SSRIs are used as the first line of treatment for PMDD. BDNF, brain-derived neurotrophic factor, is a neurotransmitter linked to estrogen and thought to be relevant to PMDD. BDNF is critical for neurogenesis and is expressed in brain regions involved in learning and memory. BDNF levels are increased by SSRIs as well as affected by estrogen. Studies have shown that women with PMDD had significantly higher serum BDNF in the luteal phase than in control patients. Also, within those PMDD patients, serum BDNF also was significantly higher in the luteal phase compared to the follicular phase. Stress and the HPA axis. Significant exposure to stress has been associated with PMDD. There is evidence of altered HPA axis function with PMDD patients, as these patients exhibit lower cortisol levels during mental stress and higher baseline cortisol levels during the luteal phase compared to controls. Brain structural and functional differences. Some structural differences in those with PMDD compared to healthy controls are greater gray matter density in the hippocampal cortex and lower gray matter density in the parahippocampal cortex. Functional differences seen as increased amygdala response to negative stimuli during the luteal phase and lower activation of the pregenial anterior cingulate cortex, along with the ventral medial prefrontal cortex across the menstrual cycle. The last piece of evidence I thought was interesting was a study done with bold reactivity. This technique is dependent on blood oxygen levels of the brain. Patients with PMDD had enhanced reactivity to social relevant stimuli as compared to non-social stimuli in the amygdala and insula, but decreased reactivity in the anterior cingulate cortex when compared to controls. Finally, on treatment. As mentioned before, antidepressants, specifically SSRIs, are the first line of treatment for PMDD. There is a use of intermittent dosing and symptom onset therapy. SSRIs have been shown to have a short onset of therapeutic action in PMDD, taking effect within hours to days, contrast to the weeks that are often required for response to SSRIs in major depression. This is likely due to the SSRI's ability to enhance formation of allo within minutes of exposure. This onset makes intermittent dosing of giving medication only during the luteal phase possible. In addition to the pharmacological treatment, psychotherapy is also used in order to help modify cognition and improve coping strategies. And that was the last piece of information I had for you guys. Thank you for watching, and I hope you enjoyed it.